Good evening, everyone. I'm Brittany Nichols, the Kansas EMSC coordinator, and I want to welcome you all to the Heartland EMS for Children Coalition's Winter Symposium. Tonight, we're going to be learning about the identification, treatment, and management of respiratory emergencies in children. Before we jump into the presentation, though, I want to go over a few housekeeping items. First, just a little bit about us. These symposiums are a product of your state's EMSC program. EMSC stands for Emergency Medical Services for Children and is a program dedicated to helping emergency care providers give the very best care to children. Each state has an EMSC program that is fully funded or partially by a grant from the federal government. Our group is called the Heartland EMS for Children Coalition. We're a group of Midwestern EMS for Children managers from Iowa, Kansas, Minnesota, Nebraska, North Dakota, and South Dakota, who have banded together to maximize our impact in our own states through pooling our ideas and resources. These pediatric symposiums were born during a pandemic from a lot of discussion about how to best bring you affordable continuing education. Since September of 2020, we have brought 19 plus hours of free CE for EMS providers, physicians, nurses, social workers, and more on topics including human trafficking, children with special healthcare needs, pediatric burns, and children's mental health emergencies, just to name a few. So next, as you might have noticed, all attendees are in listen-only mode. This just means that your mics and webcams have been automatically disabled. If you encounter any technical difficulties or need support, please utilize the chat box function and we will respond as able. And if you have questions you would like asked during the QA session, please type those into the QA box and we'll get to as many of those as we have time for. All of our attendance is going to be captured through the Zoom roster, so you do not need to put your name into the chat to get attendance credit. You do need to watch for at least 100 minutes, though, in order to receive your certificates. Please be patient and give your state EMSC coordinator some time to get your certificates to you, as we have to go through these individually just to meet our state-specific guidelines. Again, the process could take up to 1 month, so please be patient. As always, though, reach out to your state coordinator if you have any questions or concerns. An evaluation will pop up after the presentation tonight and will also be sent via email follow-up. Don't forget to take this so that we can continue to provide education that you will find relevant and impactful, and so that we can help you better meet the needs of your pediatric patients. It's completely anonymous and just an opportunity to provide some honest feedback and recommendations. And finally, if you're interested in staying up to date on these types of pediatric offerings and other opportunities, connect with your state coordinator to learn more about becoming a pediatric champion. It's just another way to share your passion for pediatric focus areas within your facility or agency and to gain access to new tools and resources. So with all of that said, let's move into our presentation for tonight. Our speakers are going to be Dr. Mira Lee and Dr. Jody Huber. They'll be walking us through how to identify and treat some current trends in viral respiratory emergencies that have been particularly prevalent among children. So Dr. Lee, Dr. Huber, we are so glad to have you with us tonight, and I'm going to turn things over to you now. So thank you so much.
Thank you, Brittany. I'm trying to get my presentation up here. Hello, everyone. I would like to thank you all for taking time out of your busy schedule to attend this educational session. Also, I would like to thank all of the organizers for giving me this wonderful opportunity to present. I'll try to keep this presentation interactive with the help of your participation. I'll try to present scenarios as well, and it will be followed by a poll allowing you to pick an answer. My hope is to keep you all engaged while keeping the ride enjoyable. With this, let's start. So we're going to talk about the pediatric airway and the emergencies that may arise out of those. I have no disclosures to make. The objectives that we are going to discuss about would be anatomic differences in pediatric versus adult airway. We'll try to identify common pediatric upper airway issues, whether it's infections, anatomic issues, and things like that. We'll discuss about what the pediatric emergencies could be and how would you manage the airway.
Dr. Ali, I just wanted to chime in real quick and let you know we can't see the slides yet.
Okay. Sorry about that. Let me see what I can do here. Can you see that now?
Yep, that looks great. Thank you.
Thank you for that. So continuing, anatomic differences between the pediatric and versus the adult airway. So remember, the pediatric infant head is normally in a natural flexion. The neck is flexed, as you see that in the picture. The occiput of the infant places the head and the neck in that flexed position by default. And when the patient is placed, especially supine, you're looking at a difficult acute angle for intubation. Nose in pediatrics, it causes 50% of the total airway resistance. So any kind of blockage that happens at the nose equals respiratory distress. The trachea in pediatrics population, it starts out at C1 of vertebra. By 7 years, it descends down to like C3, C4, or elongates. In adolescent and by adult, it's down to C4 and C5. The airway overall matures to an adult around 8 years. The cartilage is immature, the diameter of the airway is smaller, and overall it's shorter in length. The larynx is located more superiorly and anteriorly. The epiglottis is relatively long, it's floppy, and it's narrow. The narrowest portion of the airway is below the glottis at the level of the cricoid cartilage. If you look at this picture, even a small reduction in the airway, whether it's from airway edema or any kind of infection that causes swelling in the airway, will reduce almost up to 50% of the pediatric airway. As compared to an adult, you can see they still have a lot of room to breathe. So that impedes the airflow even with minimal swelling in pediatrics. You can see in this picture, the cricoid ring is the place where it's the most narrow in the pediatric airway. It almost looks like a funnel, as you see, versus the adult that is almost like a barrel. This picture also describes again how narrow it gets when it reaches the cricoid ring. Infants have a large tongue, and that tongue falls back against the posterior pharynx, and the glottic opening is hidden mostly by that large tongue. So when you're trying to look in the airway, especially during intubation, it's a challenge. Now coming to what pediatric issues can happen in the airway. As I said, the blockage of the nose, that's again the most important thing first. Many of the times you do see that simple cleaning up, suctioning kind of just relieves the respiratory distress in the child. So blockage of nose equals respiratory distress. So we're going to start off with a case. So you have a newborn that presents as turning blue when he's calm, but the color improves when he's crying. What's your diagnosis? You have a foreign body in the airway, you think it's sinusitis, choanal atresia, or malacia. You'll have 10 seconds to answer this. Great. So 42% feel that it's a foreign body in the airway. The answer is choanal atresia. So again, what are the chances that a newborn would have a foreign body? The clue here is he turns blue when he's calm. A foreign body would cause you to be continuously having, cyanosis. So what is choanal atresia? You see, this is the CT of the head, and it shows how the passage, the nasal passage comes down, and then there's no continuation of the air. So basically, it is atresia of the airway through the nostrils. Happens usually in a genetic disorder called the Chart syndrome, where they have heart defects, they have colobomas. It can present as unilateral and bilateral situation, wherein the newborn, again, gets cyanosed when he's calm, because mostly children breathe through the nose. So when they're calm, they're trying to breathe through the nose, but it's obstructed. And when you make them cry, they improve. So when you try to put in a catheter, you'll see that you cannot, especially if it's bilateral obstruction, it becomes very difficult to manage. So what you do a CT, check the anatomy at the point when, if you're needing to do some airway manipulation or adjustment, then you use the oral airway. Surgical repair is the final resolution. Case 2, you have a 10-month-old who presents with respiratory distress. Mother gives the history, has cystic fibrosis, chronic diarrhea, has a failure to thrive, and a rectal prolapse in the history. What do you think this child would have a nasal finding as? A foreign body in the airway, sinusitis, nasal polyps, a dermoid cyst? Awesome. 48% said nasal polyps. Cool. That's where you're looking at the picture of a nasal polyp. A dermoid cyst would look like that, a swelling on the upper part of the nose. Cyst can present with a dimple. It could be a pit looking. It could be a hair coming out of it. Sometimes children may have continuation of the meninges called encephaloceles. Whenever they cry, they enlarge. Remember, any of these things that are protruding through the nostril will cause obstruction and cause respiratory distress in the child. Tumors like rhabdomyosarcoma can present like that. 2-year-old presents with unilateral, purulent, foul-smelling, bloody discharge. What's your diagnosis? A foreign body in the airway, a nasal polyp again, a dermoid cyst, or a choanal atresia? Okay, 27% said foreign body in the airway. That's correct. So terrible twos, again, are notorious to put in peanuts, which are again notorious. Batteries, if put in the nostril, can be dangerous. They rarely complain of pain. So usually you see that purulent discharge, and you should have a high suspicion that there's something in the nose. A removal is the solution. I'm going to run a video, a sound track here, and then you have the x-rays down there. You're looking at the airway. I'll talk about that after we are done with this. You're looking at the x-ray of the child, and you see it kind of looks like it's kind of almost cutting off. Here you see the nice air column below, but you see again it's kind of cutting off. Same thing up here with the arrows. You can see that again it narrows down pretty much here. What's your diagnosis on that? Choanal atresia again, nasal polyps, Krupe stridor, and a dermoid cyst. Wow, I'm loving this audience. Okay, 89% said Krupe stridor, of course. Good. So stridor, remember, is a generalized term. We can have stridor with multiple etiologies. We'll come to that in the later slides. But just to kind of outline, Krupe is the most common cause of the stridor as we talk about it. A foreign body, trauma, stenosis of the airway, the malacia, infections, the epiglottitis, which is again a very notorious entity. You can have just the vocal cord dysfunction. All of these can cause stridor. Case 5, weak hoarse cry since birth, nothing else in the history. Diagnosis, foreign body in airway, vocal cord dysfunction, nasal polyps, and a dermoid cyst. Vocal cord dysfunction, you got the clue in the previous slide. Awesome. Third most common cause of stridor. It can present in brain malformations like Erner, Chiari, hydrocephalus, and myelomeningocele. Usually it ends up needing an intubation. They do the bronch and surgically correct the airway. Another case, 6-week-old NICU graduate has a history of prolonged intubation and presents with a stridor with both inspiration and expiration. What's your diagnosis? Foreign body in the airway, a vocal cord dysfunction, nasal polyp, subglottic stenosis. Subglottic stenosis, awesome. Hope I didn't give the answers too easy up here. Okay, I'm going to show 2 videos here, how a subglottic stenosis looks like.
Hey guys, it's Romaine Johnson again. Just a quick case to show you. Saw an infant, former preemie, prolonged intubation, comes in stridor, noisy breathing, difficulty feeding. Did a flex scope, and you can see here it's got looks like subglottic stenosis, pretty classic appearance. You'll also notice that the left vocal cord appears to be immobile. Here I slow the video down some, and then you can see left vocal cord is immobile, as well as the subglottic stenosis. Looks about a grade 3, maybe grade 2, but I would say probably a grade 3. So what do? Go to the operating room and do a quick DL, make sure confirm the diagnosis. Here we can see it pretty clearly. We'll go ahead and change the video, get a little bit better focus, but again, you can see the subglottic stenosis there, but it looks pretty stable, like one confined area, circumferential. We thought it was a grade 3. So what do? Go ahead and dilate. Use a balloon to dilate the stenosis, break it apart. And I felt like we got a pretty good result. We'll take a look again in a couple of weeks and see how it looks.
So as you see, it basically narrows down right below the vocal cords. So multiple intubations should be a red flag for you. Any child that has the history of those, HPV can cause this. Classic symptom is the biphasic stridor. It can be due to a vascular ring. As we talked about, acquired is mostly 90% of those, and that's due to the multiple intubations. Anaphylaxis can cause increase of the edema, and there's also a reflux sometimes can cause that from chronic reflux. Case 7, a 4-week-old presents with a hoarse cry with retractions only when he is agitated. That's the clue. Diagnosis: foreign body in the airway again, vocal cord dysfunction, malacia, and a dermoid cyst. Good. Malacia. Awesome. I'm going to show the video up here, how a malacia looks like, and we'll talk about it more. So you saw how the airway kind of tends to collapse on itself when the child is trying to breathe. So it's a collapse of the supraglottic structures inward and during inspiration. Inspiratory stridor is very classic in this. It starts around like 2 weeks of life, and it increases and gradually improves over 6 to 24 months. 15 to 60% of the kids would have airway abnormalities. Looking at the airway, if you look at this diagram here, so the normal airway would look like you are going to have a nice and smooth flow of air coming down from the larynx into the trachea. Whereas if it's a floppy airway where the arrows are, you can see as the child tries to take a breath, it basically obstructs the airway. It just falls back on itself. When the child is trying to take the breath, it causes him to have a depression in the chest, and you see that the chest is being sucked in. I'm going to run this video and we'll talk about more on this. That's the actual croup. So what is croup? Laryngotracheobronchitis. That's the technical name of that. can be caused by viral and bacterial infections. You see the retractions, you see the barking cough, there's hoarseness. Usually it's the inspiratory stridor. Almost feels like Malaysia, but usually it's not in that age group. Malaysia would be way, way early as compared to the age of this child that we just saw. Steeple sign is very classic earlier that we saw, wherein the airway column looks very narrow. Paraflu is the most common cause. You use cool air, humidified air. Racemic epi on the field is very helpful. Steroids ultimately work, and Heliox. When the kid is admitted to the pediatric ICU, we usually use Heliox. It helps to smoothen the flow of the air. Ultimately, if they don't respond, you need intubation till the airway swelling calms down. Foreign bodies. You're looking at a foreign body in the airway. You have a hair clip up there. Children tend to put anything, everything in their mouth. And you have a coin up here as well. As I said, they want to eat everything. So it can cause trauma. Sometimes it's just not children. It can be us adults also do silly things sometimes, can cause trauma and airway edema. We'll jump on to the infections, tonsils and adenoids. We'll start off with that. In the picture that you see down here, you have the adenoids and the tonsils being shown as A and T. Causes obstructive sleep apnea from the tonsils and adenoids being huge. They present with choking, gasping. Frank apnea can happen. And if you look at the X-ray, you see those enlarged adenoids. Case number 8. Very interesting. I will play the video and you're looking at the picture on the right. You're looking at a huge tonsil, but it's only on one side that you're looking at, and it's something different about these tonsils.
So, why are you here with us? What the doctor say is wrong.
The doctor said I have huge tonsils and huge adenoids. That's why I sound like this.
You sound like this. What did the doctor say does this sound like?
The doctor said it sounds like a hot potato.
A hot potato voice.
A hot potato voice, yes.
Okay. Did you eat any potatoes?
No, not at all.
But we say you have a hot potato voice.
Yes, that's what they say.
Okay. And what is the weather like in Cape Town today?
Oh, it's very windy today. Very, very windy.
And what are we doing for you tomorrow?
They're taking my tonsils out.
They're taking out my tonsils. Okay, great. Say hot potato voice again.
Hot potato voice.
Hot potato voice.
Hot potato voice.
Okay.
So what's your diagnosis? Pharyngitis, sinusitis, a tumor that you might have, or a peritonsillar abscess. Awesome. 81% said peritonsillar abscess. We'll come to that. Presents with sore throat, fever, trismus, difficulty opening the jaw, and dysphagia. They cannot eat. They have that classic hot potato voice. You see the tonsillar bulge that we saw in the picture earlier, and it literally is so much swollen that it displaces the uvula to the other side. So if you're examining a child and you see one-sided swelling of the tonsil displacing the uvula, highly suspect this. If you manipulate it, you can actually cause a rupture and it can cause aspiration pneumonitis. Antibiotics is the treatment. They usually end up going to the OR and their aspiration is done, or sometimes even a tonsillectomy. Plain tracheitis can cause stridor again. Brassy cough is very classic. They have a high fever. They look toxic. They have copious purulent secretions. They could have respiratory difficulty with tachypnea and retractions, decreased air entry in the lungs. They can lie flat. The reason why I put that in is later on we will have an entity that will not allow the child to lay down flat. So tracheitis will allow the child to lie flat. There's no drooling, there's no dysphagia, they're still eating. And when you try a racemic, the stridor doesn't go away. When you look at the x-ray, you can see subglottic, the airway has narrowing, but if you closely look at the sides of the airway, it has a ragged appearance. Now let's jump on to emergencies. What are the things that we should be wary about, we should be worried about, and keep in mind when we are going out, picking a child or treating a child? Two entities which I always have the fear of, and I think we all should. Case number 9 is going to be the first one. You look at the neck x-ray, you see the airway looks okay, but the tissue behind the airway has got this huge widened appearance. Same thing up here. And in the third picture, actually, you see the child kind of trying to be in a sniffing position, extending the head back. Diagnosis: is it tonsillitis? Is it croup, a peritonsillar abscess, or a retropharyngeal abscess? Awesome, 69% said retropharyngeal abscess. Looking at the pictures, you can see how the child looks. They have an open mouth. They're trying to keep the neck forward so that they can keep the airway open. Trauma is the most common cause. They present with drooling. Here is where the drooling part comes in. They have a muffled voice and a stridor. They cannot move the neck much because it hurts, and they can be kind of shifted towards one side. Swollen lymph nodes you may see, and the neck x-ray, as we looked at, shows the bulging in the retropharyngeal wall that is behind the airway. Antibiotics and surgical drainage of that space is the solution. Case number 10. Now, if you look at this child versus the child in the previous slide, this child still has the open mouth, but he's leaning forward. Same way, the child is trying to lean forward, sitting in what we call the classic tripod position. You see the child down here drooling. What's your diagnosis? Tonsillitis, epiglottitis, peritonsillar abscess, retropharyngeal abscess. Epiglottitis. Looks like many people have seen this. So high fever, sore throat again, dyspnea, tachypnea, stridor, that's kind of the common appearances for any kind of respiratory distress, but toxic looking. Has difficulty swallowing, but drooling is a red flag in this position. The classic tripod position they're sitting in, trying to make sure they move the epiglottis away from the airway. If you get a chance, and if you're lucky, you will see a cherry red epiglottis. And on the x-ray, you see that it's the thumb sign, we call it. Things to remember on these kind of patients: even if you suspect it is epiglottitis, avoid agitation. Antibiotics ultimately and racemic, we end up mostly intubating these children in the operating room in a very controlled environment, and it subsides subsequently. So a few polls. Avoid agitating a patient who you suspect having epiglottitis or even retropharyngeal abscess. Do not try to suction too much, or as much as possible, try to avoid it unless you really have to. Drawing the labs may agitate the child, and already the epiglottis is kind of obstructing the upper airway. It could go into an acute spasm and obstruct more. No airway manipulation. Do not try to look into the airway with the tongue depressor. And if you have anesthesia backup or an ENT backup, call them. You will need them. Let's move on. So now it's time to crash a pediatric patient. We talked about what are the infections, what can cause stridor, what can cause difficulties with the airway, but what if the child is almost about to crash? Respiratory failure. This is a very common term we all use. I'm sure all of you have talked about this multiple times. Two main things about respiratory failure is hypoxia and hypercarbia. Hypoxia is decreased oxygen and hypercarbia is increased CO2 retention. Etiologies could be multiple. All of those that we talked about in the previous slides can cause hypoxia and hypercarbia. So keeping all of those in mind, respiratory failure can be from multiple etiologies. What are the warning signs that children give us? Initially, they give you tachypnea, that's increased respiratory rate. They give you tachycardia, increased heart rate. They are grunting, they have a stridor, they are head bobbing, they're nasal flaring, they cannot lay down, they have retractions, they are agitated because the hypoxemia is causing them to get agitated, and they may show some wheezing. But what are the signs that tell you that you're going to have a catastrophe soon? Reduced air entry. If you're looking and listening to a child's chest and you see that it's silent, that's an ominous sign. The child is fatigued so much after having gone through distress that they're just not able to take enough deep breaths. Irregular breathing, persistent prolonged apnea, of course, cyanosis. Their mentation is altered. If you're looking at a child whose GCS is less than 8 with respiratory distress, that is worrisome. Special considerations should be given to patients who have neuromuscular weakness. They may not really present or show you how bad they are. Shock is also one entity wherein you may not be able to really perceive how bad the child is. So what are the strategies that we use in pediatrics if you have a respiratory failure? Suction, suction, suction. I put that in because, again, so many times we have seen multiple admissions coming even to the pediatric ICU because the nostrils were not suctioned, the airway was not suctioned, and the child continued to be in distress. So I cannot emphasize much. Be sure until there is real red flags telling you that you should not suction, make sure to clean the airway nicely. Positioning of the head. Remember, the trachea is kind of at the angle. You see in the first picture where it says the T, the trachea, that's how in the flexed position is almost obstructed. So make sure you have something under the neck or the shoulders to line up the trachea. Head positioning, keeping them in the sniffing position, keeps the airway open. If you're not having any changes or improvement with the previous ones, then you go on to non-invasive. What do we use nowadays? The high flow cannula, the RAM cannula, multiple of those cannulas out there are very helpful. It gives a extra pressure and helps the work of breathing of the child. Non-invasive ventilation continued could be CPAP. You could use the nasal mask. And if the child is a mouth breather, you could put them on BiPAP that covers the mouth as well. Nasopharyngeal airway, if you feel there is an obstruction way back just because of being congested, you can always use a nasal pharyngeal airway and keep the airway patent. You can use even an ET tube if you don't have a pharyngeal airway available. Diagram here kind of describes how you put that in. One thing to remember about a nasopharyngeal airway is basilar skull fractures. Any kind of fractures wherein you have a leak going on, either through the nostrils or through the ear canals, be aware that it could be a basilar skull fracture. And you don't want to put a nasal airway in them because that can actually get into the skull. Coagulopathy is another factor to kind of keep in mind. If the child is having excessive bleeding or is known to have any bleeding disorders, be cautious of this. So length of the airway is always a question many people ask. You look at the airway, the nasopharyngeal airway, this goes way down below. And this one shows like the ET tube as well. You can cut it short based on where you want it to be. Oropharyngeal airways, just like nasopharyngeal airway, is also another option in case of an emergency. Make sure you have the appropriate size. It should not be too long because it will go and obstruct the glottic opening. It should not be too small because then it lets the tongue still fall back and occlude the airway. You need to have a correct size. Nowadays, you have weight-based packets that come in. You can look at the child's weight, and based on that, you can go with the airway size. Proper size, as you see, angle of the mandible or the tragus from the angle of the mouth, usually that's the length that you pick if you're not able to find the packet that tells you based on the weight. Laryngeal mask, many of the EMS folks use this. It's a very good airway, but the problem with this is if you have an intact gag reflex, you are making the child again and again gag, and they can throw up and aspirate, and you cannot prevent aspiration due to this. Difficult to maintain during the transport, but in case of an emergency, is it helpful? Yes. Bag mask ventilation. I always tell everybody, learn to bag mask. It helps to save a life. The bag mask ventilation, the special technique all of us have learned, EC clamp method, wherein the fingers are kind of keeping the mask fixed on the, including the coverage of the nose and the mouth. It helps to lift the jaw and keep the seal at the same time. Well, if nothing works, you have tried all the non-invasive, then you intubate. If you're ready to intubate a child, a few things to remember is know how to pick the right size ET tube. Nowadays, you have a lot of charts and cards available to pick the size based on the child's weight and age. Have all the equipment ready in case if you need suction, in case if you need an oral airway, you're not able to get the tube in, have an oral airway around. Make sure you keep the child in the sniffing position. Use the neck and the shoulder roll to elevate the torso, remembering that we need to line up the airway in the pediatric population. Pre-oxygenate them. Make sure you have enough reserve in case if you're not able to get the tube in one shot, then maybe you may be able to at least have some time just because you pre-oxygenated. Miller straight blades are good. In younger kids, they give you a better view. You can move things around easily. Different charts, as I said, are available out there. Based on the age, you can calculate how much to push in based on different formulas out there as well. Positioning, as we talked about, if you don't have a good positioning while you're intubating, you're not going to get the tube in. Make sure you have lined up the airway nicely. Younger patients, you can put a shoulder roll, and that again pushes the head back and lines up the airway. Even when you're trying to bag mask, if you're not in a good position, then you're going to not be able to ventilate the child. So make sure you have that position before you bag. Looking at the picture up there, you can see how the airway is kind of kinked. And what you need to do is to make sure you make it straight. Different kinds of blades, the straight blade. If there is a floppy epiglottis, the straight blade is good to kind of move it around. In older children, it may be a more difficult to move the epiglottis, which is more kind of cartilaginous, you can call it in a way. So the curved blade in that situation helps. So we're coming to the end of this lecture. I'm going to just leave with some pearls again to remember. Any patient who is drooling is a red flag. Avoid agitating those patients, avoid suctioning them and trying to use long catheters to suction the back of the throat. Keep the child with the parent. Let the mom hold the child, that's okay. No labs should be drawn at that time if you worry about airway collapsing. Racemic epi helps keep them in a cool, misty environment. Heliox gas, if that's available, definitely helps. Try not to manipulate the airway. Try not to use a tongue depressor going in too deep to check to see what's in the back of the throat, unless you have a strong reason. And if anesthesia is available, you have them at as a backup. Head positioning, as we talked about, again, to re-emphasize, make sure even if you're bagging, you're putting the oral airway and trying to get air into the child. Head positioning is very important. You can use the rolls under the neck or the shoulder and learn the skill of effective bagging. It can save a life. You are in the parking lot, you are in the playground, anywhere. If you have a bag mask available, if you know the technique, you will save a life. Learn to pick the right size ET tube. If you use too big of the size, remember, you risk a chance of having a subglottic stenosis. Cuff tubes as a standard now in pediatric population, we always use cuff tubes. Less than 1 year child, if you're intubating, something to remember, they have an increased vagal tone, you can use atropine. Cricoid pressure is gone now in pediatric population. We don't use the cricoid pressure anymore. Thank you.
Thank you, Dr. Ali. We do have a few questions for you. Is it all right if we go ahead and answer those now?
Sure, please.
Awesome. Okay, first one, could you please explain charge once again? I believe you referenced that a little bit earlier in your presentation.
Sure. So it's coloboma, and it's the heart defects. You have the choanal atresia. That's 4 or 5 of those. And they have ear abnormalities. That's the full definition of the charge. It's a genetic kind of syndrome.
Gotcha. Thank you. And then could you please explain the biggest difference between epiglottis and retropharyngeal abscess, since they both have drooling? For example, if there's no x-ray available, so I'm thinking maybe for some of our EMTs in the field, how would they maybe be able to possibly differentiate when they're out in the field?
So the drooling can happen. I'll try to go back to my slides. The drooling can happen in any of those. But the epiglottis part is kind of very classic. And the position of the child, that's how you kind of pick up. If the retropharyngeal abscess is there, remember, it's behind the airway. So the child is going to try to extend the neck, versus in epiglottitis, the child is going to be in the tripod position and push the neck forward. So that's kind of a clue for you. Rest, stridor may be there, everything else may look the same. But if the child has that toxic appearance and you're not sure retropharyngeal versus epiglottitis, the position will kind of give you a clue.
Awesome, thank you. Another question on retropharyngeal abscess. Could this be caused initially by trauma and then lead to an infection in the area, or is that not as likely?
Yes, it can definitely. That's the reason I put the picture wherein the child can be trying to put pencil and stuff like in the mouth, and they can just get poked and they just cry, and nobody really pays any attention, but ultimately it gets infected and then it starts to become an abscess. Yes.
Gotcha. Okay. Do you have a strong preference for medications that you prefer to use for pediatric intubation, and do those vary based on the child's age?
It depends. Again, succinylcholine, I know many of the EMS folks use that out on the field. We kind of rarely use that. I have told this in previous EMS conferences. But fentanyl is pretty good drug. And if you're muscle relaxing, then rocuronium for most pediatric population is good. Midazolam is on the low on my list, but midazolam also is okay.
Gotcha. Thank you. And then a question, this person thought that had the AHA come out against atropine for pediatric intubation, and do you have any thoughts on that?
Have they come out, you said?
Yes, the question was, I thought the AHA was against atropine for pediatric intubation. So what is, do you have any information or a stance on that?
I am not aware of that because
Okay.
they have increased vagal tone, and many of the situation, once you're getting the tube in, it stimulates the vagal response and they go bradycardic. So less than 1 year at least, I use that.
Okay. And then it looks like this last one here, could you please provide any supportive care or intervention that, like, for example, the basic EMT could provide while en route to a critical access hospital?
Yeah, oral airway, I have seen multiple occasions, helps a lot. If you're not able to intubate and you're bagging the patient, having an oral airway helps a lot, just to keep the tongue away from the airway. Nasopharyngeal airway is also good. You can bag through that, keeping again just the whole mask covering the nose and the mouth at the same time. At least it will be like between the tongue and the posterior pharyngeal wall so that some air can get in. Many times I have had instances wherein the EMS team just could not get the tube in, unfortunately, and at least oral airway in that situation, I've said, helps. Pharyngeal, the laryngeal mask, again, it kind of tends to dislodge a lot. So again, I lean more towards an oral airway. And having the position of the head when you're bagging, again, is very important. You're bagging the child, you're looking at the chest rise, making sure the chest is rising. And if not, you adjust the head, whether it's extending the neck to make sure the airway is lined up as you're bagging. That helps as well.
Awesome. Thank you so much, Dr. Lee. I'll give it just one more minute to see if anyone else has any follow-up questions for you, but thank you so much for that presentation. Lots of great comments in the chat. Everyone really enjoyed your lecture. They liked the polling questions, having that interactive component. So thank you so much.
Thank you.
All right. So I am not seeing anything else come through. So I guess with that, we can move into Dr. Huber's presentation.
Awesome. Thank you.
Hi, hello. I'm Jody Huber. I'm also a pediatric intensivist at Sanford Children's here in Sioux Falls. I'll go ahead and get started and let me share my screen here. All right, is everyone able to see my screen?
Yep, we can see your screen, Dr. Huber.
Sounds great. Okay, I'll go ahead and get started. And just to dovetail with Dr. Ali, I'll be talking about, he spoke about upper airway disease in pediatric patients. So I'll be speaking about diseases of the lower airway. I thought it would be a nice way to talk about some of our common lower respiratory disease we see in kids, looking at bronchiolitis, especially as we come up on our usual bronchiolitis season. I know nothing's really been usual in the last year and a half or almost 2 years, but talk about bronchiolitis, a nice refresher on influenza, talk a little bit about pneumonia, specifically bacterial pneumonia. We'll talk a little bit about COVID, asthma, and then I threw pneumothorax in there. And then what are the predictions for this coming winter? Kind of the big question. It's the $1 million question for pediatrics right now. I like to start off just by going over pediatric vital signs. I always think it's important to, especially if you're not familiar with typical vital signs for children, these current signs right now up on the screen are the PALS updated vital sign guidelines that were just updated in 2020. What we do at our hospital for our pediatric nurses and for the ER nurses is we have our badges, and then we have a little vital sign card on them, and it's very helpful for people that aren't used to taking care of children. It just is a nice review of knowing what vital signs are normal, not normal for kids that age. So first of all, respiratory failure in children are a little bit different than adults. Adults, you can diagnose respiratory failure by either saying they're hypoxic or they're hypercarbic, whereas in children, we have the wild card of work of breathing can also be a definition of respiratory failure. And when we say work of breathing, children tend to have more compliant chest walls, so you are more likely to see retractions. Those could be subcostal, intercostal, suprasternal retractions, head bobbing, nasal flaring, grunting. All of those would be considered increased work of breathing, and they all contribute to respiratory failure, not just hypoxia or hypercarbia. So keeping in mind, just because a child is saturating well, if they do have a significant increased work of breathing, that also can signify respiratory failure. These are some good warning signs to look for with children with respiratory failure. Of course, tachypnea, nasal flaring, grunting, retractions, using those extra muscles, head bobbing. Some children will hesitate when they lie flat. Agitation can be a sign of hypoxia, or what we also refer to as like air hungry. Some kids wheeze, and also more worrisome, if they're not wheezing, some kids can have reduced air entry, meaning you don't hear very good breath sounds at all. And we'll talk about that when we come to the asthma section. Stridor, like Dr. Ali spoke about, cyanosis, somnolence, which could be a sign of hypercarbia, apnea, which we absolutely see, and we'll talk a little bit more about with bronchiolitis, and then pulsus paradoxus, where we see an alteration in our pulses, or a pulse oximeter or pulses with respiratory effort or with inspiration, really. Okay, so now we'll head into bronchiolitis. This is our bread and butter of pediatrics. It's a lower respiratory tract infection in infants. Usually what happens is you get inflammation of the endothelium of these lower airways, and that inflammation of that endothelium can cause sloughing. And really, I think of bronchiolitis as a disease of mucus production. Really, all of our common cold viruses can cause bronchiolitis in an infant. Most commonly, RSV is the most well known for it. But really, it can be enterovirus, human metapneumovirus, influenza, adenovirus, coronavirus. And when we say coronavirus, not COVID, but our usual coronavirus, parainfluenza. We typically see bronchiolitis in our winter months in North America here. And most commonly, it's seen, more severe bronchiolitis is seen in kids in those first 12 months of life. Absolutely, you can see severe bronchiolitis in kids that are older, especially those that have comorbid medical conditions like prematurity, some sort of chronic respiratory disease, children with neuromuscular diseases, things like that. Bronchiolitis, I always think it gives you a potpourri of respiratory symptoms. Kids could have either restrictive lung disease, so meaning they can get pockets of mucus plugging and they can get areas of atelectasis, or it can be an obstructive lung disease. So that those mucus plugs can create a ball valve effect, so air gets in, has a hard time getting out, and it can give you more of a wheezing or obstructive pattern. Kids who are at higher risk for severe disease from bronchiolitis, children with congenital heart disease, kids with chronic pulmonary diseases, excuse me, like bronchopulmonary dysplasia, kids who are premature, any kid who has immunodeficiency are kids who have cancers or primary immunodeficiencies. Some kids who have a strong family history of asthma or have had previous wheezing with colds, kids who have congenital abnormalities, or also in utero smoke exposure as well. This is just a nice illustration showing how those terminal airways, and this is really the areas that get affected most by bronchiolitis. This terminal bronchiole and then our alveoli tend to be more affected with bronchiolitis. This is a classic chest x-ray for bronchiolitis. This is why I showed it. Here you can see this perihilar infiltrate on both sides. That's very classic for bronchiolitis. And also you see this right upper lobe atelectasis. So this would be most likely some sort of mucus plug that's then plugged off that airway. So you can see some atelectasis as well. So this is classic for bronchiolitis. The way kids can present is runny nose, cough, nasal congestion. And some of the lower airway findings is tachypnea, and then again, those signs of increased work of breathing. On exam, it can vary from wheezing to crackles. You can see those increased work of breathing as well, and really a heterogeneous lung disease. Okay, so I'm just going to stop sharing here for a second and pull up. I have two videos to show. The first one shows what that cough sounds like with bronchiolitis. Once you hear that bronchiolitis cough, it's very familiar to you. And then also I have a nice video that shows increased work of breathing, so some retractions. One second. Took me a second, sorry about that. Okay, so I hope everyone's able to see my video. Okay, I have this small VRBO commercial. I'm going to skip it as soon as I can. So please excuse me with that. Okay. You can hear that very wet cough. That's very classic for RSV. And then I'll go into here. This is a nice video of what retractions look like, especially if you don't have kids of your own and you haven't seen these, what this can look like. See those subcostal retractions there. And this child also has a little bit of head bobbing too. All right, I'll go back to my other screen here. Oh, there we go. Okay, is everyone able to see me back again?
Yep, we picked right back up where we were.
Perfect, thank you. All right. That's classic. And what I always say before we get to our first question, when these kids come in, especially in the winter, and they're all bundled up, they've got that onesie on, I always suggest, and I say this when I speak with the emergency room nurses here in our emergency room, to open up that onesie, take a good look at that child's work of breathing, because sometimes it can be deceiving. Kids can look like they're not having any trouble, and then you open up that onesie and you can see all those retractions and you say, oh my goodness, you notice that. So all right, so I had a couple of questions here, our poll the audience questions. So I'm ready for my first one. Okay, so this one is, which of the following is not a management strategy for bronchiolitis? It can be oxygen, steroids, suctioning, or hydration. All right, here we go. All right, excellent. So we had some good answers here, so this will be great as we get into our next slide. Okay. So believe it or not, bronchiolitis is actually a disease that's well studied in pediatrics. Many diseases aren't. We've actually know quite a bit about bronchiolitis. We've had multiple guidelines. The most recent one came out, I believe, in 2014. I think it's the third guideline for bronchiolitis that has come out since I have been a physician. So bronchiolitis typically peaks around 3 to 4 days, and sometimes that can help guide you. If they're at day 1 and the kids look pretty rough, they're probably going to have a more severe disease. However, if it's towards the end of their course and they don't look so bad, maybe they'll be okay. So that can kind of help guide you. Typically, we manage bronchiolitis by what we say supportive measures. So we recommend oxygen in our guidelines from the American Academy of Pediatrics, recommend oxygen, suctioning, and sometimes suctioning can make a world of difference. We have these, they're called little suckers. They're these plastic suction catheters. One of them doesn't have a flange on it. The other one does, just so you do not cause like trauma for the nose. And what we do in our emergency room and up in our pediatric ICU in the floor is we'll take one of those pink saline bullets with sterile saline, squirt it in one nose and use the suction catheter in the other nose, and we'll flip-flop, and it will make a huge world of difference in that child's work of breathing. Infants are obligate nose breathers, and sometimes when you can clean their nose out well with good suction, it can make a huge difference in their work of breathing. So the other recommendation from the American Academy of Pediatrics is nebulized hypertonic saline. It's also recommended to maintain hydration, and the AAP does not recommend one versus the other, meaning whether they do that with oral intake or IV fluids. However, if the child is tachypnic, and what we tend to use as a rule of thumb is if their respiratory rate's greater than 60, we tend to hold off on letting them eat orally. But if it's under 60, we do let kids eat orally. If they are not eating well or they're more tachypnic, we do use IV fluids. There's been numerous studies about the use of bronchodilators in children with bronchiolitis, and they have not shown a huge difference in their management. My pearl to that is that there are going to be children who do respond. Those kids who have underlying reactive airway, so a strong family history of asthma, a personal history of wheezing with colds, or maybe that child's a premature infant that has underlying chronic lung disease. Those kids very well could be good responders to bronchodilators, so I would recommend their use. I usually, if a child ends up sick enough in an ICU and they are wheezing, I will try bronchodilators. However, if it's an otherwise healthy child that has bronchiolitis, they tend not to be helpful. The AAP does not recommend chest physiotherapies like CPT, where we use those percussors. Studies have shown those have not been helpful. Continuous pulse oximetry on the regular pediatric floor has not been shown to be helpful in weaning oxygen, and what they rather recommend is spot O2 checks. Now, of course, if you're up in the pediatric ICU, that's a little bit different story. But if you are on the floor, they do recommend just spot checks. Steroids have not shown to be helpful for bronchiolitis. And of course, neither have antibiotics since it's a viral disease. However, children can get secondary bacterial pneumonia, so it is important if that child isn't improving or they've had a worsening in their condition, I would recommend getting a chest x-ray, CBC, looking for those signs of possible bacterial pneumonia. But so for our answer on that previous question, it was steroids. So, now we tend to use high flow nasal cannula for bronchiolitis. Some of the newer studies have come out to say it doesn't shorten hospitalization rates or length of stay. I will say that we do use high flow nasal cannula. I find that it personally, anecdotally, that it helps with children's symptoms, meaning if that child's breathing in the 80s and 90s and having increased work of breathing, that high flow nasal cannula can help with their work of breathing, and it can help with their tachypnea. Maybe it doesn't get them out of the hospital sooner, but I tend to think that it does help. I didn't want to get too specific on high flow nasal cannula protocols. This is the protocol that we use at our institution, but each institution may do it a little bit differently. So I didn't want to get too hung up on that. And I would say for the EMS providers, touching base with the institutions that you serve with your services about what they like to use for their protocols, because I hate to say one thing and then your institution that you bring patients to does something different. We tend to start if they're under 10 kilos. 10 kilos or under, we start at 6 liters per minute. Between 10 and 20 kilos, we start at 8 liters, and greater than 20 kilos, we start at 10 liters. And then we have a protocol to see, you know, what does the child look like after that, and is the child still having trouble, and then we will increase our settings If they are looking good, then we do talk about weaning parameters. I hate to speak too much about this. There isn't a lot of evidence out there for where to start kids on it. It's just kind of what your institution does. But I'm happy to answer questions about it further. We tend to prevent bronchiolitis with our monoclonal antibody, or it's not a monoclonal antibody, excuse me. It's a passive antibody, so it's actual antibodies of RSV. It's called palivizumab. I can never pronounce it. Other people call it Synagis. There are very strict recommendations for its use. It is very expensive, and most states, Medicaid, have very specific instructions about who qualifies for Synagis and who doesn't. According to the AAP, they tend to say if it's within the first year of life, you either have congenital heart disease or some sort of chronic lung disease of prematurity. And they define that as you were born less than 32 weeks and had an oxygen requirement for 28 days of life. Typically, we give 5 doses. It usually starts now in November, and we go through into the spring. The last dose is usually in about April, March, April. Otherwise, we recommend what everybody's been hearing about for the last year and a half, 2 years: good hand washing, hand sanitizing, and avoiding ill contacts. So that's my spiel on bronchiolitis. I'll segue into influenza here. Influenza is a very common lower respiratory tract infection in children. And I read this great article in preparing for this talk that was published in Pediatrics just this last year. In children, actually have the highest attack rates for influenza, meaning they tend to get infected easier with influenza, and they tend to be responsible for transmission, which is kind of the opposite of what you've been hearing about for COVID. So I found that really fascinating. And complications are not uncommon in children. Kids usually present similar to adults with fever, body aches, fatigue, headaches, cough, sore throat. Also in kids, they can present with gastroenteritis symptoms too. So that can, a little bit different than adults, but they can definitely have GI symptoms. Complications with influenza can also occur. They're not uncommon. And I tell you, we get a little bit biased in the ICU because you tend to see the worst of the worst. So you think all influenza is bad because we see all of these complications. We definitely see febrile seizures. I've seen children who have had transverse myelitis or Guillain-Barré after their influenza infection. Every 4 or 5 years, we see a child who has encephalitis from their influenza, and we've actually seen deaths from that as well. You can get myocarditis. I tend to think of influenza B as being a little bit more common cause rather than A with myocarditis. You can absolutely get secondary bacterial pneumonias, strep pneumo, Staph aureus. We've seen MRSA, which is such an aggressive infection. We've seen that with influenza, and of course myositis too. So. Okay, now we're going to segue into our second question. So this one says, which of these children is at high risk for complications from influenza? And our options are a child with Crohn's disease who is on Remicade, or that's infliximab, that's a monoclonal antibody. A 2-year-old who's a former 24-week preterm infant who takes Flovent, an inhaled steroid daily. A child with cerebral palsy who is nonverbal and G-tube dependent. An otherwise healthy 14-year-old with a BMI greater than the 99th percentile, or all of the above. All right, great answers. Okay, good. Okay, great. So that segues into our next slide. Excuse me. These are the children that tend to be at high risk for complications. Really, they say the younger the child, the higher the risk they are for complications, especially those under 2 years, which is why we recommend flu vaccines, which we'll get into the coming slides, for parents or grandparents or family members that do have young children. Just to not only are you protecting yourself, but also to protect those children from becoming sick with influenza. But really, really what it boils down to are kids with high medical needs. So kids with chronic pulmonary disease, so cystic fibrosis, asthma, former premature infants with bronchopulmonary dysplasia, children with congenital heart disease, kids who have renal disease. Really, it kind of goes the whole gamut. Our children with neurodevelopmental conditions like cerebral palsy, seizures. Of course, our kids who are immunocompromised, kids who have trachs, home ventilators, obese children, and kids who live in chronic care facilities. We have one here in town, and I know there's lots of good facilities. I know in Omaha and Minneapolis that take care of a lot of these children too that are going to be high risk for influenza. For treatment, we tend to recommend our neuraminidase inhibitors. There is also amantadine, which is not a neuraminidase inhibitor, but it is not really used much anymore. Tamiflu is the oral version, oral seltamivir. However, in the last couple of years, they came out with an IV version, peramivir, which is what we tend to use in the ICU if we're not able to use Tamiflu. The recommendations are to start treatment within 48 hours. So who should be treated? We tend to recommend treatment for those that have who have severe disease. So basically anyone that's hospitalized, whether that's on the floor or in the ICU, someone who's at risk for severe disease. So going back to that previous slide, those are our high-risk kids. Or if it's a child that lives in a home where there's an unimmunized, whether it's a sibling or a parent, grandparent that's unimmunized, we would recommend them being treated as well, just to prevent that other family member from having complications. You can do chemoprophylaxis for influenza. It's recommended for those who have high risk for complications. So going back to our previous slides, those who are higher risk, or those that are unimmunized and also have could be at a high risk. We tend to recommend starting treatment, or excuse me, prophylaxis within 48 hours of the exposure. And the reason they're so strict about that is because the studies showed that it can shorten your course if it started within that window of time. If you're outside of that window, the likelihood of it helping isn't very great. I will admit though, when we do have a critically ill child, if it's been more than 48 hours, we will try a neuraminidase inhibitor. They do not recommend it for those less than 3 months because of some neurological side effects from the medication. So influenza prevention, we're in the peak of that right now. Flu shots, there's 2 different types of flu shots you can get. There's the inactivated influenza vaccine and the live attenuated influenza vaccine. Both of these vaccines contain 2 strains of the influenza A and 2 strains of influenza B. All of our vaccines nowadays are quadrivalent. The live attenuated influenza vaccine, that's the nose one. And so some people opt for that because it's not a shot, and some kids are a little bit more amenable to that than the shot. However, since it is a live attenuated virus, there are certain populations that we don't give it to, and those would be kids with immunodeficiencies, asplenia, which would be a type of immunodeficiency. The reason we worry about cochlear implants or CSF leaks is because you are doing it in the nose with the potential of creating like a CNS infection. Asthma is not listed on here as a contraindication. However, if they are a child with asthma, you may want to be a little bit more cautious with its use. Egg allergies are not, I double checked this before this talk, egg allergies are not considered a contraindication to getting a flu vaccine. It is considered safe in those with egg allergies. This is the true statement, 80% of influenza-associated pediatric deaths occur in the unvaccinated. Every influenza death that I have ever seen is from an unvaccinated child, never in a vaccinated child. So, the administration of flu vaccines is a little bit unique in pediatrics. You have to be 6 months old to get your first flu vaccine. And so for 6 months through 8 years of age, we recommend 2 doses of the vaccine 4 weeks apart. And then after that first time you get it, those 2 split doses, then you can get it just once a year. And if you're 9 years or older, you can just get the 1 dose. I hope that makes sense. But primary care providers are really well versed in that. Then we'll kind of segue into pneumonia. Pneumonia is the single greatest cause of death in children worldwide. We just kind of talked about some of the viral causes for pneumonia. So I was going to focus this on our bacterial or community acquired bacterial pneumonia. And the most common one is going to be strep pneumonia. The other 2 culprits are Haemophilus influenza and Moraxella. Staph aureus can occur Usually it's secondary, most commonly with influenza. And even in that case, it can be MRSA, and you can get a very, very, very sick child with that. It's uncommon to see fungal pneumonias. I just threw it on there to be complete, but I wanted to focus on the 3 main community-acquired bacteria. This is from the IDSA, or the Infectious Disease Society of America. They came out with this nice article in 2011, and it's really complete. And so I know it might be a little bit old, but this was a great article. This talked about when to hospitalize kids when they have pneumonia. Pneumonia is common, happens often in children in the winter. But we tend to hospitalize them if their SATs are less than 90%, usually in that younger age group, just because they tend to have a risk of getting a little bit sicker. If it's a bacteria that tends to be higher virulence, like MRSA, or there's concern for, are they able to get their antibiotics? Usually we have kids come out to the ICU if they need some sort of non-invasive or invasive mechanical ventilation. If it appears that they're entering respiratory failure, of course, low blood pressure or altered mental status are always reasons to have people come out to the ICU. This was a nice table, and this just really summarized our criteria for respiratory distress, which I know we already kind of talked about that, but retractions, grunting, nasal flaring, apnea. You tend to see apnea usually, I always think of those kids in 1 month or under, or those kids that are the near term or preterm. I never trust them, and apnea can definitely occur in those kids. The diagnosis of pneumonia most commonly will use markers for inflammation, so a CBC or a CRP or procalcitonin, chest x-ray. The viral PCR panels can be nice. They can help guide you. They are expensive, but they can help guide you. It's really hard for kids to give a sputum sample. If they're an older child or an adolescent and they can produce a good sample, it's worth it. But a lot of times our kids just tend to give you saliva, and so it's hard to get a good true sputum sample. Blood cultures, we check those. It's when they're positive, it's impressive, but it's uncommon to see positive blood culture, but we always check for it. The one thing we don't do is there is a urine antigen test for strep pneumonia. We do not use that in kids because it has a high false positive rate. I know the adult world uses it, but we do not use that in kids. Really what I would say is chest x-ray, symptoms, and a CBC or like a CRP or procalcitonin are probably our most common methods. So our pneumonia guidelines that have not changed over a number of years. If it's a child that's fully immunized, we recommend ampicillin. And that's because those immunizations will cover for certain types of Haemophilus, certain types of pneumococcus. And so ampicillins are our main recommendation. If it's a child that's not immunized or not fully immunized, we give Rocephin, and that's because we worry about some of those more aggressive strains of pneumococcus that would otherwise get covered in a child's vaccination schedule. I tend to think of mycoplasma after kids become school-aged, so in that 5 and older range. It's not common to see those atypical pneumonias in kids younger than that. However, if there is a concern for mycoplasma, we do use azithromycin. And that's a nice benefit of those viral respiratory panels. Mycoplasma is a bacteria, but we do test for mycoplasma and chlamydia pneumonias on our viral panels. And so that is an instance where it's very helpful. Of course, if you're worried about MRSA, then vancomycin or clindamycin would be a nice addition. There can always be complications with pneumonia. The biggest thing we worry about is effusions and whether those effusions can become empyemas, and then when do you drain that? Kids can also get lung abscesses. We have seen bronchopleural fistulas and necrotizing pneumonia. I will say those two are most common in kids with MRSA. That's really when we see those. I would say it's probably the most common thing. This is a nice graph from that same article. I know it's very busy. I didn't want to spend a lot of time on this, but just to show you that how we tend to follow kids who have effusions and how we follow that effusion to see if we need to place a chest tube. Do we do a chest tube with fibrinolysis, or do we do a VATS procedure? That's where they go in and do a thoracoscopic surgery where they remove all that pus out of the chest wall. Okay, so that's my 2 seconds on bacterial pneumonia. And then I wanted to touch base a little bit on COVID. It has not left our minds for almost 2 years. I know you've probably heard a lot about COVID, so I was just going to give a brief update. It's a large enveloped single-stranded RNA virus. It's a different strain from our usual run-of-the-mill coronavirus, which we do see every winter. It's a common cold virus. What we know about COVID is it enters cells through the ACE2 receptor, and I have a really nice picture on the next slide that shows that. You can see these ACE2 receptors in the lungs, heart, small intestine, kidney, and bladder. This is a really nice illustration, and I have one on the next slide too that came out of this JAMA article last summer. But really what it shows here is this here is our S protein, or the spike protein, and you hear a lot about that because a lot of the monoclonal antibodies that you hear about on the news or read about, this is what those monoclonal antibodies attack that then gets rid of the virus. So anyway, that's that spike protein. And it binds here to this ACE2 receptor and this other receptor called TMPRSS2. And by binding to these two receptors, that's how it gains entry into our cells and then wreaks havoc. This is a really nice illustration from the same article in JAMA, which shows this is one of our cells within, this is our alveolus, or one of our lung sacs. And it shows here that virus getting made using the cell machinery in this cell in our alveoli, and then it's spitting out all this virus, and this virus just wreaks a lot of havoc. It calls in lymphocytes, neutrophils, monocytes, and they release all these inflammatory markers, and that wreaks all this havoc and inflammation in the lung tissue. And I think a lot of the problems that we see, especially in those adults who are long haulers, comes from that chronic inflammation, all from this inflammatory response. Children tend to differ a little bit in their symptoms for COVID. The Society of Critical Care Medicine has this COVID registry, and I just checked this about 2 weeks ago when I was preparing this talk. So I have this does have the most updated information. So this, according to our COVID registry with our Critical Care Society, 67% of kids who had COVID had a fever. The second most common one was nausea and vomiting. Then dry cough and abdominal pain, followed by shortness of breath. So I think what's impressive here is kids tend to present with more GI symptoms. Of course, they have fever, but more GI symptoms compared to adults. Just to help you kind of get a grasp on what COVID looks like in kids. It does look a little bit different. Okay, here's our next question. This one's a COVID related one. Okay, so which pre-existing condition or conditions are associated with severe COVID-19 in children? Our options are obesity, developmental delay or delays, epilepsy, asthma, or all of the above. All right, awesome. Great answers. Okay. Okay, and this is according to our SCCM, our COVID registry, they actually keep track of this. And asthma is the most common cause. It's a little bit, again, it's a little different in kids than adults. Asthma is the most common cause or pre-existing condition, followed by epilepsy. So thinking of those kids that have chronic healthcare needs like epilepsy, developmental delays, like cerebral palsy, intellectual disabilities, followed by obesity, diabetes, and then lastly, those kids with cerebral palsy. So anyway, it definitely looks a little bit different than our adults that all of you have probably taken care of quite a bit. So again, COVID can look a little bit different in kids. We tend to support children similarly to adults. Oxygen therapy is needed, whether that's a nasal cannula, a mask, high flow. And then we definitely have taken care of some children who've been intubated with COVID, although nowhere near what the adult population has. There was just an article that came out this year in Critical Care Medicine that talked about, they did a really nice job of summarizing aerosol generating procedures. I'm sure all of you in the as first responders have concerns about that when you intubate patients with COVID. And the big three that they found in this study was endotracheal intubation, non-invasive ventilations like a CPAP or BiPAP, From that, there's an exhalation valve with those CPAP and BiPAP that can spread virus into the air. And then nebulized medications, so like albuterol, things like that have been shown to be aerosol generating procedures. So really, I would say just making sure you have your PPE on when you're taking care of these patients. As far as management goes now, remdesivir, there's been a couple newer studies that came out that actually don't really show that it's quite as helpful. And so right now we are revisiting this with our pediatric protocol. I'm in the process right now of working with our infectious disease specialists about whether we should be using this medication. But right now we tend to use it in kids with COVID who are sick but not too sick, those who are hospitalized but yet not critically ill. Dexamethasone has been shown in very large scale studies to be helpful for COVID-19. And in fact, we've used steroids. We've had a couple teenagers who've been long haulers that we've used steroids in. And I would say steroids have shown to be the one true medication that makes a difference. If it's a child who is high risk and is still within the 10-day window of their diagnosis, we do recommend those monoclonal antibodies. They're for that spike protein. They have definitely been shown to reduce hospitalization, reduce ICU admission, and intubation. It is only approved for those 12 years and older, so we cannot use it in those under 12 years. But we definitely do it in our children's hospital. Our hospitalists are in charge of that, and we have a whole little protocol that we follow. But if it is a child who's high risk that gets COVID, I would recommend monoclonal antibodies. This is according to our registry. The most common mode that we see in the ICU is high flow nasal cannula, not surprising, followed by intubation or non-invasive ventilation. So very few kids end up with dialysis or ECMO. Okay, that's my little bit on COVID. I purposely didn't really say too much about MISC since this was more of a respiratory focused talk. But I'm happy to chat about MISC if anyone has questions at the end. Then asthma. Asthma is probably one of our most common ICU admissions that we see, and I'm sure as EMS providers you see it quite a bit. I tend to think of asthma as this triad of bronchospasm, airway inflammation, and increased mucus production. And really when you think of those three, looking at how we target and how we treat asthma really makes sense if you go back to those are our three main problems. Infections can trigger an asthma attack, otherwise allergic reactions. We live in such a rural area where agriculture is our primary economy. And so especially when you get into seasons where like in the fall when it's harvest or in the spring when everything's blossoming, you can definitely see asthma exacerbations. And of course, infectious causes. My one story with that, in 2014, when we had the enterovirus D68 outbreak, we were just overflowing. We were busting at the seams with children with status asthmaticus, and it all happened in August and September. And I kept thinking about what pollen was there that's triggering this. And then we ended up figuring out it was this enterovirus D68, whereas all along I thought it was from all the pollens from the harvest. So it was interesting. Asthma creates an obstructive lung disease. So in other words, you get, whether it's from that bronchoconstriction, mucus production, or airway inflammation, air gets into that lower airway, but then has a hard time getting out. And with all, you can hear get mucus production and of course bronchospasm. This is the classic chest x-ray for somebody with status asthmaticus. You can see how hyperinflated those lungs are. Usually a chest x-ray is expanded about 8 to 9 ribs. In this child's, I think 10 or 11 ribs expanded. Those diaphragms usually sit nice and plump, and the heart just kind of rests on that diaphragm. Whereas here you can see those diaphragms are flattened and the heart almost looks squeezed because of all that air trapping that this child has. So what we see is air gets in, it just really has a hard time getting out. Some signs, what I always say with kids is I always try to get them to talk to me. I try to get them to tell me a story, tell me about their siblings or a family pet. I find something to get them to talk to me or tell me a story. And I use that as my guide to see how severe their asthma is. If they're able to tell me a whole story about their dog, their breathing probably isn't that compromised. However, we just had a young lady within the last year up in our ICU, and she couldn't even answer yes or no to what medications she was taking at home. And so right there, that tells you how severe her asthma was. So I tend to use that as a guide. And of course, otherwise, shortness of breath, accessory muscle use. The other big thing is absent breath sounds or diminished breath sounds are very concerning. So if you listen to that chest and it sounds silent, that should be worrisome for severe air trapping. So just because a child isn't wheezing doesn't mean they can't have asthma. And we definitely have seen that, or I've seen that in my career, where once you give a couple nebs, then you start hearing the wheezing. And that's just from severe airway obstruction. Oh, I have this video on wheezing. So just one sec, I'm going to stop sharing and show this last, or it's not really a video, it's just a sound bite. So 1 second. Okay, so this is the child that's wheezing. And you can hear that prolonged expiration. You hear all that extra noise with exhalation. All right. Okay. So here's my last question. I threw these in there just to give some excitement to the talk. So here's our last question about asthma. Okay, so which of the following is associated with near fatal asthma? A previous ICU admission, younger age, previous hospital admission, or ability to recognize difficulty breathing? All right, great, good. So we'll talk about some of these risk factors on the next slide. Okay, so these are some risk factors for fatal or near fatal status asthmaticus. And I would say, to me, there's nothing scarier than a really sick asthmatic. If you just feel very out of control in how you can help this child. So I have a lot of respect for asthma.
Real quick, Dr. Huber, it looks like on the screen we're still seeing your YouTube page.
Oh,
the slide.
Gosh, I'm sorry. Okay, 1 second.
No worries.
Sorry about that.
Just wanted to let
Thank
you
you
know.
for letting me know. Are you seeing it now?
Yep, it just popped up. Perfect. Thank you
Sorry
so
about
much.
that. I was just at this question, so let me pop ahead. I apologize about that. So this is a nice nice little box that shows our risk factors for fatal or near fatal status asthmaticus. So the first one is, and I always ask these questions when kids come into the ICU, if they've ever been admitted to the ICU before with asthma, if they've ever been intubated with asthma. Children of an older age, that's not to say younger kids can't have fatal or near fatal asthma, but older age. And the other thing is kids who have a hard time, or parents, family members or children, they have a hard time recognizing their symptoms, or I don't know if it's denial of symptoms or a hard time recognizing their symptoms. And then of course, poor compliance or poor asthma control. A couple of years ago, there was an adolescent that I took care of who was a football player and collapsed out on the field during practice because he was not using his inhaler and did not recognize his symptoms. So pretty impressive, and especially teenagers, I would say, tend to be a little bit more stoic about admitting their symptoms. So in that last question, it was the child that had the previous ICU admission, and then I did opposites for the others. So. Okay, I tend to think of asthma management is tiered therapy. In that first tier, so this is what you provide, or you first responders are going to provide is, oxygen, bronchodilators, whether that's an albuterol or an Atrovent, whatever you carry with you, bronchodilators, steroids. I tend to think of asthmatics as being fluid depleted in needing IV fluids because they tend to have these hyperexpanded chests, and you saw how small that heart was on chest x-ray. And so I like to give them IV fluids. I think that it helps their heart fill and provide better cardiac output. So I always give kids who have severe asthma fluid boluses. Magnesium is a smooth muscle relaxer, so help with that bronchoconstriction. Magnesium can make a big difference. And so that's what I tend to think of as what our first responders are providing, what our emergency room providers are doing. And then once you get up to the ICU, we tend to think about those second tier therapies, and we'll use IV bronchodilators. Terbutaline are most common one we use. We'll also use, if the child, we'll use a helium oxygen mixture called Heliox, and that doesn't do so much for the asthma management, but it just helps to get good airflow into the lungs. We tend to use CPAP or BiPAP. It sounds counterintuitive, but actually studies have shown that non-invasive ventilation actually reduces the risk of intubation in asthmatics. There's old school medications called methylxanthines, theophylline's the oral version, aminophyline's the IV one. They do work. The caveat to those is that they have a really narrow therapeutic window, so meaning you can get toxicities from them easy. So we tend to use them not quite as often. Ketamine's an IV sedative that also is a good bronchodilator. So if you ever have an intubated asthmatic, ketamine would be your drug of choice. And then third tier therapy, we tend to try to avoid intubating asthmatics if possible, only because they're very difficult to ventilate. And a lot of times the kids do a better job on their own of managing their ratio of inhaling to exhaling. And we just have a hard time mimicking that with the ventilator. So we usually try to avoid intubation unless the child is has impending respiratory failure. You can use inhaled anesthesia. Isoflurane is what all the studies have been done with, but that can be a potent bronchodilator. And then our last ditch effort would be ECMO, and that would be more just to provide adequate CO2 removal and oxygenation while you're working on breaking that bronchospasm. So that was my bit on asthma. Lastly, pneumothorax. This is a chest x-ray that shows a classic pneumothorax in an infant. You can see this child here is intubated, and you can see their heart over here. And then you can see this is what their right lung looks like, and then you see this pneumothorax all around it. They can be spontaneous. They can happen in kids with connective tissue disorders or trauma. You as first responders, when you encounter kids with trauma, infections, meaning like pneumonias, especially those severe pneumonias like necrotizing ones or ones with bronchopleural fistulas, you can get pneumothorax. Kids will definitely complain of chest pain, hypoxia. Some of them will have increased work of breathing or grunting. And then of course our chest x-ray here shows what we say mediastinal shift, so meaning the heart is pushed over here into the left chest just because this is lung is collapsed. Physical exam, you can hear absent breath sounds, or you don't really hear much at all for breath sounds. If it is a tension pneumothorax, you can see changes in your vital signs like hypotension, bradycardia or tachycardia, and that would be a little bit more urgent cause. We tend to do a needle decompression. Here you can see it, it's between the second and third rib. Mid-clavicular line is where you want to do that to get rid of that extra air. And this is an example of that. But usually we treat kids with a needle decompression, chest tube placement, oxygen as well. And then chest tubes hurt, and so we usually get some pain control. And then the last thing I wanted to talk about was our viral patterns for this upcoming winter. And I put a crystal ball there because I will say that's our $1 million question, and that's what the world of pediatrics is talking about right now. I looked at the CDC website. I couldn't really find good answers for this question. I did some lit searching too and couldn't really find anything. So finally I went and asked our infectious disease specialist, and he laughed at me as well and said that he's been getting asked that a lot. And we don't know. What is concerning is for pediatrics, we've had a rough summer and fall with viral infections, RSV, regular coronavirus, COVID, rhinoenterovirus, adenovirus. We've just been really hit hard with viruses. I thought there would be a lull, but it doesn't really seem to be happening, and we're entering into now our RSV season. I think what has people most concerned is, are we going to get a combination of COVID, influenza, and RSV? And that's what I think has people the most worried. The other thing is that with influenza, we usually pick our strains for our flu vaccine from what's going on in the Southern Hemisphere, because their winter is our summer. And so usually you look and see what happens in Australia, what happens in South America, and that's where we make our flu vaccine. And our flu seasons have really not been very existent with COVID. And so is our flu vaccine going to match what influenza strains are floating around this winter? And we don't know that. So we do have the possibility for a severe influenza winter. And then also that COVID's floating around, and our viruses are back with a vengeance. So we just have to pay close attention to what's going on, and hope for the best, but prepare for a rough winter is what I would say. These are some references I used. And I'm happy to take questions if anybody has any.
Hi, Dr. Huber. Thank you so much. And I've got a lot of great questions that have come in here through the chat and through the Q&A. So if it's all right with you, I'm going to go ahead and just kind of dive in and start going through those. So first up, this was a question about, in addition to the use of bronchodilators, this person was curious about the use of Atrovent, so a combination of albuterol and Atrovent.
Oh, yes, duonebs. Yeah, oh, I'm sorry, I used the trade name. Yes, there is a combination neb of albuterol and Atrovent. Duoneb is the trade name for it. And absolutely, there was I'm sorry, I did not mention that. For asthma, was it a question for asthma?
They didn't list it specifically, but it looks like it was a little bit earlier in the presentation. So I'm guessing.
It might have been, sure, with bronchiolitis. We do try duonebs. If it's a child who has bronchiolitis that either has a history of chronic lung disease or an asthma history, we will do duonebs, and they do work well. And I apologize, I didn't mention this in the asthma piece. There was a great study in pediatric emergency rooms where they looked at the use of duonebs. And what they found was when they used back-to-back duonebs, when a child entered the emergency room for an asthma exacerbation, that the back-to-back duonebs actually prevented hospitalization. And so it's really common now to see people trying that when they see a child with respiratory distress due to an airway obstruction issue. So whether that's a kid who has bronchiolitis that has an asthma history or an asthmatic, to use those back-to-back duonebs, and it absolutely can make a difference. So that's a great point. Thank you for bringing that up.
Awesome, thank you. Another question is, for your slides that contained guidelines, would you be able to either share like the slides or maybe just the guidelines? Because I know that there were some slides that had a lot of information, and I think folks were just hoping they'd be able to reference some of that later on and maybe share some of their own practices.
Yes, I'm happy to share my slides. Also, I can send the references to Kelsey and Corolla. I'm happy to send those references. Mm-hmm.
Thank you. Our children, oh, sorry.
I'm going to make a note of that, otherwise I'll forget.
Oh, no worries. I'm the same way.
Okay.
Are children with HSV more susceptible to influenza and COVID?
With HSV, like herpes virus?
That's what I'm wondering. So we can come back to that for clarification, but it looks like, yeah, HSV for herpes simplex virus is what's being referenced.
No, so as far as, so what we have seen is, especially with this second round with the Delta variant, and this is in my institution, and so I apologize, I'm speaking for what I've seen anecdotally. We have seen kids with co-infections this second time around with the Delta variant, where they've come in with RSV, rhinoenterovirus, adenovirus, and COVID, like combination viruses like that. I have not seen it with HSV, but definitely we have seen it this second go around with other viruses.
Gotcha, thank you. And I think this references back when you were talking about influenza deaths, how 80% of pediatric deaths are in unvaccinated children. They just want some clarification. Are you referring to just strictly children who haven't received the influenza vaccine, or is that children who haven't received any of the recommended childhood vaccinations?
Yes, I apologize about that. Yes, it's children who haven't received their flu vaccines. Okay.
If a patient has received a monoclonal antibody and then is admitted for worsening COVID symptoms later in the day, how long would you recommend waiting to administer steroids so that you don't decrease the effectiveness of the monoclonal antibodies?
Oh, I see what you're saying. I don't think I would still use steroids. I don't think the steroids will have quite as much effect. The big thing about the monoclonal antibodies, this is my understanding, is we wouldn't want to give a vaccine to somebody who's had the monoclonal antibodies within a 90-day window, because it will diminish the effectiveness of the vaccine. I mean, it could diminish, I guess the big picture would be, I think the cat's out of the bag if your symptoms are that severe that I don't know that the monoclonal antibody would help you, and I would probably go ahead and use your steroids, if that makes sense. We use the monoclonal antibody for people who aren't sick yet, but because what it does is it prevents the virus from replicating or from having more of an effect on the patient. And if it already is having a negative effect, I feel like kind of the cat's out of the bag, the horse out of the barn, and I would go ahead and use steroids.
Gotcha. Thank you. And kind of following up with the topic of monoclonal antibodies, have you seen any bowel obstruction with monoclonal antibodies or with COVID infection in general in children?
I haven't. We do give monoclonal antibodies, and in all honesty, I haven't seen a child that's gotten and get admitted. Now, that is at our institution. That's not to say that I would talk to the specialists at the institutions that you bring your children to, but I have not seen that in our kids. And ever since this, we had a number of kids in the winter, and then it died down. And then with this second surge with the Delta variant this fall, we've definitely had an uptick in our monoclonal antibody use. And I haven't seen that. I haven't even seen any of those kids get admitted.
Gotcha. And this one looks like it might be kind of both for you and then for any of our EMS agency directors who are on the call and want to type their answer into the chat. But Dr. Huber, do you know have an idea of how many ALS services kind of in your area carry MAG specifically for management of asthma? And then I would go ahead and pose that to all of our EMS agency directors in the chat as well, if you want to put in how many of you carry MAG for the management of asthma.
I don't think they would. I would say that's probably in the emergency room. Okay. I would guess the EMS providers are going to have bronchodilators like your albuterol, possibly Atrovent. But I agree they're probably not going to have MAG, but an ER will have MAG. Gotcha. And I would defer to the other directors out there, but I would guess that.
Thank you. What dose do you recommend for ketamine with asthma?
So our intubation dose, we use 2 milligrams per kilogram. However, if you're not intubating that child, I always use something lower, like maybe 0.5 milligrams per kilo, 1 milligram per kilo. Keeping in mind, it is a good sedative. One of the benefits of ketamine is that it doesn't cause a lot of respiratory depression, but it can increase secretions. So just so you're aware of that. But I would say if it's a non-intubated child, I would use a lower dose, like maybe 0.5 or 1 milligram per kilo.
Gotcha.
And it is a short-acting medication. It's quite short-acting. Half-life is about maybe like 10 minutes, 15 minutes. And if you are using ketamine, I would have intubation equipment around you just in case that child were to have some difficulty breathing with that sedative.
Gotcha. Do you have any recommendations for needle sizes for a needle decompression in peds? And then do you know if there's a reference for the different weight-based color systems?
That's a good question. I don't know. I would think just something small. You're just looking to get air out. So I would probably say like a 22 gauge would probably be appropriate. Because again, or even if you have like a butterfly, like a 22 gauge butterfly, you're just looking to get air out, not fluid. And so I would say just something small.
And then, oh, I like this. This person says they're a strange combination of an ambulance first responder and an immunization nurse, and was curious if you see just in general more infectious diseases in children that aren't immunized, kind of, I guess, like across the board.
I just from my ICU experience, I would say we see more severe disease in kids who aren't immunized, specifically, Haemophilus, pneumococcus, meningitis in kids who are not fully immunized. I would say, I don't know if I would say, I don't know how to, I don't have a good answer for the more frequent infections, but I would say more severe infections from my scope and what I see.
Excellent, thank you. And this is another follow-up for the ketamine question. Do you see the same hallucination side effects with ketamine use in children as you do in your adult patients?
Yes, you can. And that is one of the reasons it's not as popular as some of our other medications. You can, it's not as severe as an adult, but you can. Sometimes what we'll use is little Versed, but again, you got to be careful that you would end up having to intubate that child. So I would be a little cautious with that. So globally, yes, but not as severe as adults, I would say.
Perfect. And then there were a couple questions related to flu vaccine. So first up, this person had a question. Do you split the first flu vaccine dose between the 6 months to 8 years of age?
Yes, here I'm going to go back to my slide. I don't mean to give people headaches. Oh, here it is. Okay, yes. So if they're 6 months to 8 years of age and it's their first time getting the flu vaccine, we split the dose and you get half a dose, and then 4 weeks later you get the second half. And then after that, the following year, you can get the full dose at one time, if that makes sense.
Absolutely. And then do you have any advice for how to kind of promote influenza vaccination for parents of children? Just because I know that's not something, parents always think of for their kids, since it's, I think it can be one of those ones that it's easy to think of, well, that's just for older adults. Do you have any advice for how to kind of promote that in children?
I agree. It is hard. When the flu vaccine is actually an old vaccine. I looked this up just recently. It actually came out in the 1930s. Some people tend to think that it's a new vaccine. It's actually older than polio, the polio vaccine, which I find interesting. It's older than the measles vaccine. Wow. So it's been around for a long time. The tricky thing with influenza is that it was always recommended for the elderly. And it wasn't until the last, 15, 20 years that we've started to recommend it for more and more people. And now it is recommended for everybody. I always stress that it's an old vaccine. It's a tried and true vaccine. And in that it's safe. I think there is misnomers in people describing its effectiveness. And I think that we in the medical community don't do the best job of explaining what that means when we talk about effectiveness. When they say it's 65% effective, what they mean by that is that it reduces clinic visits by 65%. And then you can extrapolate that to it reduces hospitalizations by more and ICU admissions by even more, and then deaths by even more. So you can, they don't publish it that way, and I don't know why. But I would say I would stress the potential complications of influenza, and there is we talk about these high-risk categories for influenza, but really just a normal healthy child who's unvaccinated can end up in an ICU with influenza. I tend to stress how safe they are, and I usually talk with families about what the effectiveness means, and the CDC website does do a nice job of explaining that. And I usually talk about the complications of influenza, which unfortunately are not really talked about a whole lot. But I can tell you, all of us in our PICU group have a child that we always remember that had influenza that didn't survive. I think in the other facilities that EMS providers service, probably all of a story of an otherwise healthy child that came in and died of influenza.
I think this looks like the last one here I have on flu, but the live attenuated influenza vaccine, the one that can be given nasally, Are there any perhaps like nasal deformities or conditions that would also be a contraindication? For example, in Dr. Ali's presentation, he referenced some children with nasal polyps and that sort of causing airway issues. So I was just kind of curious about that.
I would probably double check with the CDC has all the contraindications listed. I would probably, yes, avoid it, but I would double check. The CDC website would have those exact details. My off the cuff opinion would be I'd probably avoid it, but the CDC website under their influenza section does list all the contraindications.
Gotcha. Then a couple here related to COVID. Do you know why we see more GI symptoms in children with COVID versus adults? Is that just kind of the presentation, or has there been any kind of studies and research, maybe alluding to the rationale behind that?
I'm not aware of any studies. I know that there are ACE2 receptors in the small intestine, so I don't know if it has something to do with that. But I'm not aware of any studies other than we kind of learned early on that kids do tend to have more GI symptoms, and we sort of use that as a clue. But I'm not aware of any studies.
Gotcha. And then the other one was just kind of some questions about maybe a little bit of general information about kind of what you've seen with that MIS-C syndrome.
So we had a big surge of MIS-C last winter, and then we've had a little bit again this fall. It didn't seem to be as severe for us anyway as it was this winter. However, when we did see kids with MIS-C, they always had fevers, they always had rashes. And some of them were really impressive rashes, conjunctivitis, and they had a lot of GI symptoms, meaning like diarrhea, severe abdominal pain. And I would say those were probably the top symptoms that we saw. We also saw a lot of kids with cardiac arrhythmias. It was pretty impressive, and some depressed cardiac function. Maybe the child didn't complain of it, but the second you got that EKG or hooked them up to our heart monitor, they had some arrhythmias. And we had some kids with some decreased function on echo as well, hypotension. So I would say those are probably the most common symptoms that we saw. These kids looked sick. Like when you first saw them, they looked sick. And we followed, there's a guideline from the American College of Rheumatology. And so we just treat our children with IVIG and IV steroids. And it's impressive. After about 24 to 36 hours, they look like a new child. They look so much better. And as far as their arrhythmias as well, their arrhythmias would get better, their function would get better. Our cardiologists follow up these kids long-term as what's recommended. And what we saw was children who were sick over the winter that they followed up through the summer, all of their cardiac issues did improve and got better. So that was made us all feel really good.
No, that's good to hear. And this is kind of a strange one. This is just kind of a callback to something you'd just briefly mentioned, but you'd mentioned that you don't generally use the urine strep pneumonia test in children because of the high rates of false positive compared to adults. Do you know why that is? Is that just kind of one of those
I don't know why that is.
Okay.
That dates back to my training that I was taught not to use it. And to be honest with you, I kind of forgotten about that test. And then when I was prepping for this talk, I came across and I go, oh yeah, that's right. I forgot that there was a urine strep antigen test. But yes, I do not know the exact reason why. I just do know that it is known to be inaccurate in kids.
Okay, gotcha. And then let's see, I know we'd had time slotted until 9:30, so I'm going to give everyone about another minute here to go ahead and put in any additional questions you have for Dr. Huber. Then there were just a couple I wanted to make sure I had a chance to address before we close for the evening. There was a lot of great information presented. Do you have any recommendations for where to go for additional training if folks are curious? Because I know pediatric respiratory, that is such a big area. There's so much information out there. So do you have any advice for where to go for more information and training if anyone's still curious and wants more information?
I'm trying to think of the free resources. You know what is great? There is so Boston Children's, which is this amazing children's hospital in Boston. It's probably our best children's hospital in the world. Their PICU and one of their intensivists started this website called Open Pediatrics, and it's all one word. If you Google Open Pediatrics as one word, and it's a free resource. They started it with a grant, and Open Pediatrics has a lot. They have informational videos. They have like a ventilator simulator. They have handouts, talks, and it all focuses on children. And you can narrow it down to respiratory stuff, but it has all kinds of stuff, information on there. And that's a free resource. You do have to register where you create a username and a password, but I tell you what, they don't send you junk email or anything like that. And they don't, as far as I know, I've had a membership, or not member, I've had a password and stuff for years and years. And it's a wonderful resource. We have our pediatric residents use that tool, and it's a free tool. And I would say if you're looking for free stuff, it's a great resource, and it's called Open Pediatrics, all one word. Otherwise, if you're looking for general infectious disease information, the CDC has really great information on it, on stuff about whether you're talking about influenza, pneumonia, RSV, and it does have great information. And it actually has really good COVID information too. I think that I find the CDC website a great resource.
Gotcha. Thank you. That's a good one. And then here's more of a general question, but kind of specifically thinking about respiratory patients. What are some good recommendations for ensuring proper handoff from the EMS personnel to the ED team?
I've always experienced very good handoffs from the EMS providers that I've witnessed. They usually do a nice job of summarizing how the child presented, what the child looks like from a physical exam standpoint, what they've done for interventions. I tend to think those are the biggest things to highlight when you're handing it off. I've always personally found the EMS providers that serve our institution do a wonderful job of handing off, I think, and those are usually what they highlight.
Thank you. And then the last one I always like to ask our presenters is, what would be your number one takeaway? If, for some reason everyone could only remember one thing, what's the biggest piece of information you would everyone to walk away with tonight?
I would say on getting used to pediatric vital signs. If you're not familiar with them, carrying them around on a card if you can, just to get used to what's normal, what's not normal. And with that, understanding the pediatric respiratory exam, in that children tend to have increased work of breathing, and that can be a sign of respiratory failure. So those retractions, that grunting, the head bobbing, those can all be signs of respiratory failure.
Awesome. All right. Well, Dr. Hubert, thank you so much. I am not seeing any more questions come in through the Q&A, just lots of, gratitude. And everyone really enjoyed your presentation tonight. So again, thank you for being here with us.
Thank you. I appreciate you asking us to participate. This was a great opportunity. So thank you.
Absolutely. And then to everyone who attended, thank you all for being here with us tonight. Just a reminder, for those of you who have attended for at least 100 minutes, you will be receiving certificates for credit. However, please give your state coordinators time to get these issued, as it may take up to a few weeks to arrive. And in addition, please make sure to complete those evaluations. We're going to be pulling up a slide that will have the QR code that'll take you directly to that survey, as well as sending that out via email. In addition, please keep an eye out for a save the date for our January symposium. We're going to be discussing human trafficking and recognition of Human Trafficking Prevention Month in January. So again, please feel free to reach out to your state EMSC coordinator if you have any questions or concerns. But otherwise, everyone take care, stay safe, and have a great night.